Good morning, everybody. This is Dr. Deepchand Raja. I am a cardiac electrophysiologist. I would like to thank the organizing committee for giving me this wonderful opportunity to speak in STEM India 2022. We are going to look at ventricular arrhythmias in acute coronary syndromes. An ACS event itself is a complex clinical situation. And when such a STEMI event is being complicated furthermore by ventricular arrhythmias, it becomes a nightmare, not only for the clinician, for the patient, and for the whole of the CCU staff. Usually, the incidence of ventricular arrhythmias in acute coronary syndromes has come down over the years. And that's mainly because of the early reperfusion that we have been able to achieve. And when one looks at ventricular arrhythmias in an ACS, it's usually one of the three settings. The first one is no or partial revascularization. As I said, the ventricular arrhythmic events in an ACS has definitely come down over the years, but nevertheless, there have been clinical situations where we have not been able to achieve a complete revascularization to the patient. There could be a lot of reasons for why we couldn't. But then such a partial revascularization is more the clinical template that we see more often nowadays when we face ventricular arrhythmias in ACS. Delayed presentation. The duration that a myocardium has been ischemic has been shown to be directly related to the increased incidence of ventricular arrhythmias. The concept is such a long duration of ischemia in a myocardium, you subject them to reperfusion injuries, that gives rise to a complex arrhythmogenic substrate. A substrate which is conducive to ventricular arrhythmias, ventricular tachycardia, sustained, non-sustained, VT storms, and ventricular fibrillation. And the next clinical situation is an arrhythmogenic predisposition. It could be, for example, a post-bypass patient now faced with a STEMI. He must already be having a scarred myocardium over there, a substrate which can give rise to ventricular arrhythmias. And then this acute ischemic event could precipitate a VT or a VT storm in those patients. Another arrhythmogenic predisposition is the genetic. And we have been able to find out the loci of this patients who are genetically predisposition to ventricular arrhythmia, especially ventricular fibrillation, which is the chromosome 21 and the short arm of chromosome 21, locus 21 again. So arrhythmogenic predisposition, delayed presentation, and no or partial revascularization is either one of these settings or a combination of these settings, which is responsible for ventricular arrhythmias in ACS. There was this beautiful study that came up this year, which showered a lot of light on the incidence and the prognosis of ventricular arrhythmias in ACS from the United Kingdom, from the NIH. So this is a contemporary evaluation of the incidence, which quotes the incidence to be around 3%. It's a very large cohort. They had 13,000 patients of ACS. And then ventricular arrhythmias was directly related to 2 times increased risk of in-hospital mortality in these patients, 5 times increased hazards of recurrent ventricular arrhythmias, and 36% increase in long-term mortality in these patients who are faced with ventricular arrhythmias. As I went through the study, there was one important highlight which I wanted to discuss. In the arm with ventricular arrhythmias, it was important to note that 50% of these patients had STEMI, but then there were also 40% of the patients whose presentation was in fact non-ST segment elevation, and 8% with unstable angina, which means ST segment elevation is not a necessary prerequisite for ventricular arrhythmias in ACE. It is this onset of ischemia because of occlusion or non-occlusion MI in the background of a myocardial substrate that is responsible for these ventricular arrhythmias and not the presentation per se. So the best way to discuss the clinical situations would be to go through some clinical cases. We have two beautiful cases to discuss in the due course, which we will be discussing the management options of ventricular arrhythmias. The first one, a 55-year-old female who presented to us with inferior wall myocardial infarction. She presented to us in cardiogenic shock. She had a high-grade AV block. The total ischemic time was 5 hours. This was the presentation ECG, as you see. The inferior leads, 2, 3, and AVF had ST segment elevation. The patient was in ventricular bigermany. And there was a P wave sitting on the ST segment of the ventricular premature complex. So that was the 2:1 AV block going on in this patient. So the patient was taken up for an invasive coronary angiogram, which revealed a occluded proximal right coronary vessel. This patient was offered complete revascularization because the left coronaries were normal. And as you can see, post PCI, the ST segment seems to have resolved considerably in the inferior lead. However, ventricular bigermany seems to persist. And as you can see on the coronary angiogram, the vessel was completely painted and TIMI3 flow was achieved. Of course, a temporary pacemaker wire was in the patient for the next 48 hours because of the bradycardia and the heart block that we had seen pre-PCI. What happened 48 hours post-PCI was a nightmare. The patient had 14 DC shocks, a clinical situation where what we describe as a VT storm, multiple episodes of polymorphic VT, ventricular fibrillation. The ejection fraction, however, was quite satisfactory, which was she presented with 30%, and then that improved to 40% post-PCI. This is one particular trace of a polymorphic ventricular tachycardia run, but there were many, many such episodes. As a protocol, correction of electrolytes, IV magnesium boluses were administered, IV amiodarone and lignocaine. First amiodarone, the patient did not respond to 300 milligram sequential boluses of amiodarone 150 each. She was on infusion amiodarone and then lignocaine as well. We had to be careful with amiodarone because the patient did have a long QT that we could note on the ECG. One thing was very sure with the ECG is that we were not facing any ischemia here because we were very confident that the coronaries were revascularized. As I said, the QT was prolonged. The patient continued to have these PVCs. There was no ischemia, electrolytes are within range. What do you do next? The strategy that was adopted here was overdrive pacing of the ventricle. Of course, the temporary pacing wire was already in. It served two purposes. One, the bradycardia, so we could overcome the bradycardia. In fact, the PVCs were seen more during the bradycardia. And the patient had an underlying long QT as well. So the patient was overdrive paced at 120. Luckily, the patient's ejection fraction was 40%. The patient was hemodynamically tolerant to this overdrive pacing. But then, yes, the patient did not have much of those episodes of polymorphic VT and VF, but we continued to see runs of ventricular tachycardia in the patient in spite of overdrive pacing. So what to do next? We had to go back to our first ECG at presentation, see what we are facing. The patient presented to us in ventricular bigermany. On the fourth day, the patient continues to have polymorphic VT and VF. A close look at this ECG reveals we could see the first 3 beats of the polymorphic VT and VF, which has exactly the same morphology as the patient had PVCs on the very first day. In fact, if you remember, I showed you the post-PCI ECG also had the ventricular bigeminy, and the morphology was exactly the same. So time for a little more history elicitation from the patient. We asked more history from the patient. Do you have any pre-existing problem, madam? And she came up with an answer, yes. She is known to have these idiopathic PVCs in the past. She was not on any treatment. She was not symptomatic. And these PVCs seems to have been benign earlier when her heart was structurally normal. But now, the same PVCs of the past, in the context of an RV infarction that she has sustained now, and has been causing an erythmogenic substrate, a trigger and a reentry circuit because of the infarction, an erythmogenic substrate for the VT storm. So this is it. The patient had a pre-existing erythmogenic substrate in form of PVC, and now the RV infarction, and that's the setup for the VT storm in this patient. We took the patient for an electroanatomical mapping. As you can see in sinus rhythm, the first 2 complexes of sinus rhythm, there were some late potentials seen on the right ventricular outflow tract. And these late potentials, fractionated potentials, were preceding the onset of the QRS during the PVCs. And we had a number of these examples of PVCs triggering VTs on table during the electroanatomical mapping. The right ventricular outflow tract, the voltage that we had studied during the study was fractionated, a lot of late potentials that we could see on the right ventricular outflow tract, which means the RV infarction was causing a considerable amount of scar in the outflow. Not only that, when we were mapping the PVCs, we localized the PVCs to rise from one of these zones of low voltage. And it was clearly a trigger caused by the PVCs and a re-entry caused by the surrounding infarcted zone that was causing this substrate for VT storm in this patient. We went ahead with radiofrequency ablation, as you can see on the 12-lead trace. As and immediately the first PVC ablation was delivered, the PVCs disappeared. There was no ventricular tachycardia post-radiofrequency ablation. The patient's QT interval, however, continued to be prolonged in spite of switching her off all the antiarrhythmic drugs except for beta blockers. And we had seen a lot of substrate on the right ventricular outflow tract, which means she was at a predisposition of more of these ventricular tachycardias should they occur in the future. So she was offered a dual chamber ICD and she was discharged on the 14th day. A case number 2 here, an anterior wall myocardial infarction. A 62-year-old male. Here, however, the total ischemic time was even long, 11 hours. A very close look on this ECG, what you will find is a high-grade AV block going on in the context of an anterior wall myocardial infarction, which is a very bad prognosis, cardiogenic shock, high-grade AV block, anterior wall MI, a delayed presentation. And of course, a flush occlusion of proximal RCA with coexisting occlusion, or not occlusion, I would say 99 significant stenosis in the left circumflex as well. The patient was on IRBP and temporary YSN. Post PCI to both the LAD and the circumflex, beautiful results, ST segment resolved, some PVCs coming up though. This same patient again, on day 7, the patient was in the ward, suffered a cardiac arrest, multiple cycles of CPR delivered, and the patient revived and shifted back to the coronary care unit. The patient had recorded multiple runs of polymorphic ventricular tachycardia. Severe LV dysfunction in this patient. The QT was normal. There was no ongoing ischemia because we had revascularized both the vessels. There was no ST segment elevation more and what we could see on the ECG. The patient was put on invasive ventilation. The patient was inotrope, vasopressors, blood pressure really crashing, and we are having a tough time managing all of them. The electrolytes were normal, intravenous magnesium given, amiodarone given, lignocaine given, patient on low-dose beta blockers. as well. What next? You have tried everything on your kit. This is one last thing that we could offer to the patient, stellate ganglion block. We needed more sympathetic suppression in addition to the beta blockers and the invasive ventilation and deep sedation that we had offered, because the patient was continuing to throw these ventricular tachycardia. Left-sided stellate ganglion block was delivered bedside. Next 48 hours, no ventricular tachycardia, no polymorphic VT, we are all very happy. But post 48 hours, we continue to see non-sustained runs of polymorphic VT. Little more close look onto this ECG. What I would like to emphasize here as an electrophysiologist, what is triggering these polymorphic runs of VT? As I have highlighted here, it is these PVCs, again, which are monomorphic, that have been triggering these runs of polymorphic VT. The patient was taken up for a mapping study. And these PVCs, again, on table were shown to cause multiple runs of ventricular tachycardia as well. They were localized to the anterolateral papillary muscle, and there was much of scar around the anterolateral pap muscle region, which is the anterolateral left ventricle, the free wall of the left ventricle. And as I show here, the very late fractionated potentials in sinus rhythm preceding the onset of the PVCs. Ablation was performed with the aid of an intracardiac echocardiogram. And then post-ventricular tachycardia ablation, no VT, no PVCs. The patient was discharged on an ICD on the 14th day. So two different clinical scenarios to highlight all the existing management options that we had used to deliver comprehensive care to these patients. Electrolytes, magnesium, the first thing that needs to be taken care of. Amiodarone and lignocaine seem to be the only two drugs with a relatively safe profile, a good efficacy safety profile among all the antiarrhythmic drugs. Class 1A and 1C agents are not to be used. Overdrive pacing is a very good option to not only to suppress the PVCs, but also to shorten the QT and to overcome the bradycardia-driven PVCs. Sympathetic suppression should be tried first with beta blockade, then you upgrade to deep sedation, and if still not responding, stellate ganglion block is always an option. And the role of electrophysiologists is try to identify these triggers for polymorphic VT and VT, try to address these triggers, which we, as we have shown in both the cases, had a very beautiful and satisfactory result to the ablation of these substrate-driven polymorphic VTs and ventricular fibrillation. Thank you all for your patient listening. I hope you all enjoyed both the cases, and wish you all very, very best for the conference. Thank you.